gonna go to school and party. He went to Boulder. And my stepdad was like, I am not paying for you to go to school so you party. So guess what? Funds are cut off. He's like, but dad, like you better do something serious or seriously, funds are off. He's like, fine, I'll be a doctor. He did it.
I'll do this.
He actually did it. I was like, wow. Of course, my stepdad didn't offer me anything, so. I feel butthurt right up. They're not my kid. Ask your own dad. I don't even know if I should plug in my stuff because it really has no purpose.
They can hear. So like we turned off the sound to the computer because they can't hear. There was like such a terrible
Feedback and stuff.
Yeah.
I'm gonna do this because they keep hiding behind the screen and I can't see their beautiful faces.
Yo,
Duck
Uh,
Fontaine.
the FYI, the recording starts that you guys are being recorded.
Oh, hello, greetings.
Yeah. I can Annika's on. I can share your window.
Thank you so much.
You're welcome.
Like, why is my bright light so bright?
Yeah.
That's confusing.
Wait, let me see if Jan can see you. Carlee, here's your pointer.
Okay. Hopefully I don't need
So
one.
that this microphone is not like smack in your face.
I
Just gonna do this.
project. Presentation. Which one was that? Someone, oh, they forwarded in one of the you don't get these, the national emails. Somebody has put together a presentation about concurrent care and we sent it out to community hospice agencies. Clearly, it's a challenge for many. Someone said something out yesterday, if there was on the glycerol, and this morning, that they have this.
Alright, you can see your presentation.
They kind of not. Yep. On directly in reverse. You share screen?
You can share, yeah, because I was playing. So you can exit out of this. Your screen, this one. Here. I don't know why yours is this. The PowerPoint's not popping up on the share window. Oh, I didn't see that.
Share. Yeah, I just shared it and I picked the window that like what I wanted. It is not a personal favorite, but it is many people's favorite.
Great. Let me see if okay.
And now this. I like writing the video. Don likes to drink his, so. Carlee has made these as well, but she prefers to heat hers up. Yes. And use a little less liquid, I think, to make them. Like work and all that. It's.
Are you?
With a hole. And. But I'm sure it's. It's
Look fantastic. Yeah. Oh my gosh, I'm so excited to be here.
Yeah. Um. I'm sure we shouldn't like do this. Like I'm doing it.
Okay.
Last night. Okay. Yeah. 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 Did you?
By that time,
Yes, it was.
Yeah, it's just.
Yeah. I think it's actually
Good morning. How's it going?
It's no.
Extremely. Oh, yeah, that was cute. Yes. I
That's what I found out. Every day, all day, and she loved
I didn't put the button.
Yeah.
Some, like actual refund. Involved. Good one.
EPOA disagreed.
Just there's some situations like how friendly started to so never. It's a change, right? You know, it's like, you guys do pretty well. That's like, you
Understand. Those.
There actually had some of those emails that pardon me, so I think I get hundreds of times. There was a recent subject last from the Carson people, so you probably like dig those emails and find a card that might not be in front of them.
Good.
We did that, emails. Yeah.
Thank you.
Yes.
Yeah. You guys got me. Right? I think you've heard introduction. Ready for Alex?
I'm ready.
All right. Morning, everyone. So this morning we have Dr. Fontaine. She's a native of Montana. She attended undergrad at Montana State University, and then she was part of the Montana Wayne Medical School. During her fourth year sub-I, she rotated through the Boise VA for the rest of the degree. She was in internal medicine and chief resident here at Boise VA before going to Tulane University for her in Europe for another care fellowship. Give it up to Dr. Fontaine.
Thank you all. I'm super excited to be here. They told me earlier that they don't have a mic that's working, but any of you know me well. Projecting is not one of the things that I struggle with. If, however, that seems to have changed, just let me know in the back and I'll speak up. I, as a consequence of my job, spend a lot of time thinking about dying. And I'm also one of those people who asks the question, why a lot? Like a 2-year-old, why does that work that way? And so when those two things collided, this research came about. So, oops, let's see. Here we go. I have no financial disclosures. I'm going to do my best to present the facts of these cases as neutrally as possible. I do have strong opinions about all of them, and so some of those opinions may bleed through. Those opinions are my own and do not reflect the opinions of any sponsoring organization. I do have a few goals for today's presentation. I'd like to define several terms: coma, minimally conscious state, vegetative states, and brain death, as well as discuss the historical context which has prompted their use. We'll also be spending the majority of our time discussing several court cases, which are responsible for the laws surrounding dying, as well as some of the ethical issues which arose during those cases. There will be time for questions and discussions at the end, but please, if things come up as we go, don't hesitate to jump in. I am not able to see the chat function on Teams, so if somebody could keep an eye out for that, and if somebody has questions, just like shoot a hand up and I'll answer them. Before we launch in, I'd like for us to take a quick pause. We are going to be discussing the deaths of 5 women, and it may have some triggering content. Please take care of yourselves and take care of each other. If anybody needs to get up and take a break, I totally understand. Okay, so let's talk about some of the terms which are going to feature in the discussions of our cases. First up is coma. This is a word that we use often in the medical field, which I think in some ways has really diluted its meaning. Scientifically, a coma represents a type of brain failure characterized by deep unconsciousness. It's often referred to as eyes closed, unresponsive state. The eyes closed portion is important for later. It's often an in-between state where patients can either recover or they can progress to one of the other more severe types of brain failure, which we will discuss in a little bit. On a pathophysiologic level, comas are induced by a disruption in the supply of either oxygen or glucose to the brain, which has lots of underlying etiologies. Common problems on the differential include hypo or hyperglycemia, toxic ingestions, severe infection, medication overdoses, or even sodium imbalances. Structural brain problems, including bleeding, clotting, so really anything that messes with intracranial pressure can also lead to comas. It's relatively rare, encompassing roughly 0.4% of all ED patients. Although I will say when you add in all traumatic brain injuries that present to the ER, that number goes up pretty significantly. Most commonly in the ER, the presentations are acute primary brain lesions, such as like a stroke, then sepsis, intoxications, and metabolic conditions. And roughly a third of patients will have more than one etiology causing their coma. Moving down the spectrum of brain failure, our next definition is that of minimally conscious state. This is a relatively new term, first defined in 2002 by the Aspen Work Group. They described patients who were unconscious but had some amount of inconsistent but reproducible awareness. That reproducible portion is important. These patients are most often severely disabled and require artificial nutrition and hydration, but are able to breathe independently. One of the criteria is also that these patients are able to experience pain and suffering. This matters most when we talk about our final definition. Generally speaking, I don't love this verbiage. I think our ability to accurately define pain and suffering in these patients is flawed at a minimum. But based on some like functional MRIs, studies, and that sort of thing, that's how we get to this idea that they are able to experience pain and suffering. Okay. There are three main etiologies which might cause a person to be in a minimally conscious state. The first is developmental or congenital injuries. These most commonly happen at or around the time of birth. And this was actually a relatively common reason that my team, the palliative care team, was consulted to the NICU during my fellowship. Other etiologies include acquired injuries to the brain, such as severe stroke or traumatic brain injuries. And then finally, progressive diseases of the central nervous system can also lead to a patient being in a minimally conscious state. An example would be our patients with severe fast 7B Alzheimer's dementia. Diagnosis of minimally conscious state requires at least one of the criteria listed here. Notably, yes or no responses can be gestural, such as a thumbs up or an eye blink, or verbal. And they don't necessarily need to reflect the intent of the patient. Some amount of intelligible speech counts. Again, this speech does not necessarily need to make sense in the context of a conversation. Finally, any purposeful behavior, such as an emotional response, which is appropriate to an emotional stimulus, making a vocalization or gesture in response to a question, and tracking eye movements. I will say this evaluation is particularly challenging in patients who have baseline sensory deficits, like many of our patients here with profound deafness or blindness, and in those patients who have underlying motor deficits, such as those with severe Parkinson's disease. When you think about the prognosis of minimally conscious state, recovery is possible, although the asterisk reminds us that possibility and probability are two separate things. Patients who are going to experience improvement must show reliable and consistent demonstration of functional communication, whether this is verbal or gestural, and functional use of 2 different objects. So this could be something like combing your hair with a brush or writing on a piece of paper with a pencil. Generally, it's very difficult to prognosticate, and the likelihood of improvement diminishes over time. As you might expect, those with progressive etiology, such as Alzheimer's, will have a significantly worse but also more predictable prognosis than those who have a traumatic etiology. Questions on minimally conscious state, because that one's kind of new and different. Our third term to define is vegetative state. And this was first described by Brian Jennett and Fred Plume in 1972 as eyes opened unconsciousness, which is different from coma, remember. This is also distinct from minimally conscious state in that while these patients may experience spontaneous eye opening or reflexive movements, they're completely unaware of themselves or their surroundings. They are felt to be unable to experience pain or suffering, although will be noted to reflexively withdraw from noxious stimuli. These patients are typically able to breathe on their own unless there's a secondary process underlying, but do require artificial nutrition and hydration if the goal is for life prolongation. Considered a rare to ultra rare condition with 0.2 to 6.1 patients per 100,000. And I'll say generally there's been a big push to move away from the term vegetative state. So this comes from a proposal in 2010 for the term unresponsive wakefulness syndrome. There is a lot of concern that vegetative state is a highly stigmatized term, as you might imagine. Unresponsive wakefulness syndrome is also more descriptive of what is actually happening to the patient, and anytime the name actually describes what's happening, I think that is preferable. For the purposes of this talk, I will be using the term vegetative state, as this is the term that is used in the court cases. This is the diagnostic criteria for vegetative state. These patients exhibit no interaction with others, their surroundings, or self-awareness. They do not appear to comprehend language, nor do they communicate in any form. These patients may have non-purposeful movements and may withdraw reflexively from pain, but movements are otherwise not sustained or, more importantly, reproducible in a voluntary fashion. Similar to minimally conscious state and coma, the prognostication for vegetative state is quite challenging and highly dependent on the underlying cause. If a patient has been classified as having a vegetative state for more than a month, then this is where we switch into the language persistent vegetative state. If a patient has developed vegetative state from an anoxic injury, such as after a cardiopulmonary arrest, and their symptoms have not improved after 3 months, then it is considered to be permanent. If, however, their underlying etiology is something traumatic, like a terrible car accident or severe stroke, then the prognostic window is lengthened to a year. As we might expect, underlying comorbidities and age will play a role in how patients recover. And unfortunately, there's no standard of care recommendations to treat to reverse vegetative state. Generally speaking, most of these patients whose surrogates elect to prolong their lives will end up in a Medicaid nursing home, unless they're very independently wealthy and can pay for, hospital level care at home. And their final cause of death is typically infection, such as pneumonia, urinary tract infection, or infected wounds. While patients with coma, minimally conscious state, and vegetative state are typically able to breathe on their own, our next term is partially defined as requiring ventilator support for prolongation of organ function. The first ventilators, if we can call them that, were developed as far back as the 1860s. People have been trying to help people breathe artificially for a really long time. The iron lung, as developed by Philip Dinker and Luis Agassiz in 1928 was the first to become the sort of mainstream and truly revolutionized care for polio patients. It utilized negative pressure to force these patients' lungs to expand and contract. The major downside to these machines, as you might imagine, was that their entire bodies, aside from their head, were encapsulated within the machine, which really limited the amount of assessment and also interventions that the medical team was able to provide. In 1951, an anesthesiologist in Copenhagen hypothesized that positive pressure ventilation might be superior to negative pressure. And he achieved this, as one could only do in the 1950s, by performing tracheostomies and manually ventilating these patients. Overnight, the mortality of his patients, specifically his polio patients, decreased from 87% to 40%. And the words developed to care for these patients in particular are felt to be the inspiration for the modern day ICUs that we know and love today. Finally, a little bit later in the 1950s, the Engstrom ventilator was developed and allowed patients to be intubated intubated by an endotracheal tube and receive intermittent positive pressure ventilation. Brain death exists as a concept as a direct result of the development of these ventilators. The first patient with brain death was described by physicians in the late 1950s in France. And about a decade later, the Harvard Medical School put together the definition, which is still widely used today. As ventilators became more sophisticated and our ability in the medical field to keep people alive continued to grow, there has become a greater need to define death by cardiopulmonary criteria, which I think we're all familiar with, as well as by neurologic criteria. And this led to the Uniform Determination of Death Act in 1981, which included brain death as a type of legal death. This was further supported by the 2012 WHO International Forum, which declared brain death could be listed as an official cause of death on death certificates and paperwork. Brain death, or death by neurologic criteria, as is the more correct term, is caused by any acute catastrophic injury, which results in a loss of cerebral perfusion. This is most commonly caused by cardiopulmonary arrest in this country specifically, with TBIs and brain bleeds as being other slightly less common causes. It's still relatively rare and comprises roughly 2% of in-hospital deaths in Western countries. In order to declare the diagnosis of brain death, there's a series of criteria which the patient must meet. You can see it here. We must have a good handle on the underlying etiology, which is often a little bit of a challenge when we're finding these people with an unwitnessed event. If the presentation is felt to be related to toxic ingestion, then we must allow for 5 half-lives of the drug or toxin to wash out before the diagnosis can be made. Additionally, as the old adage goes, they're not dead until they're warm and dead. The patient must be euthermic in order to make these evaluations. They must also have a systolic blood pressure of at least 100, which if they're unable to do on their own, that can be artificially supported with pressors. And then they must undergo a thorough neurologic exam, which is looking for things like brainstem reflexes. Certain seats and certain facilities require this exam to be done by 2 physicians. And once all of this criteria has been met, then the patient undergoes apnea testing. If they fail this test, then they can be given the diagnosis of death by neurologic criteria. It's not required by law, but some facilities will also use other ancillary tests, which include things like cerebral angiography, transcranial ultrasound, which is what we would use for our pediatric patients, and radionucleotide, brain imaging, and somatosensory evoked potentials on EEG, just looking for blood flow and function of the brain. While brain death is considered legal death in all 50 states in this country, there are exceptions in New Jersey and New York called the conscience clause, where if there is a religious opposition to the diagnosis, as in certain like Orthodox Jewish cultures, then death can only be pronounced based on circulatory respiratory criteria. It's also worth noting that the formal definition of brain death is not globally accepted. Specifically, the sticking point is around if brain stem death is adequate or if whole brain death must be present. The reason for this controversy is the concern that severe locked-in syndrome could be a mimicker of brain stem death. Additionally, there is just some controversy around brain death as a cause of death within the context of organ donation. So donation after brain death is the most common source of livers in the United States, despite liver donation being something that a live human can do to another live human. And there are those who express concern that physicians are pressured to declare brain death so that their organs may be harvested and used for other patients. This is the too long, didn't read slide to summarize the last 16 slides, which highlights the difference between these diagnoses based on their functional ability and the location of their injury. Are there any other questions at this moment? All right, that was a 10 count. Now that we have these definitions in mind, let's discuss 5 women who have changed the legal landscape of dying. Our first case is that of Karen Ann Quinlan. Karen was 21 on April 19th, 1975, when for unclear reasons, she stopped breathing twice for prolonged periods of time. Karen was ultimately resuscitated and intubated, and an NG tube was placed for artificial nutrition and hydration. She was noted in the hospital to be unresponsive, even to deep pain. She was initially diagnosed as being in a coma, and then subsequently several days later as being in a persistent vegetative state. We can acknowledge at this time that by modern criteria, the medical team did not wait long enough to make this diagnosis. Regardless, Karen's family initially did not agree on how to proceed with Karen's care. Her mother and her siblings wanted to remove her from life support and transition to end-of-life care. Her father was conflicted and concerned that such an action would be considered a sin. After discussion with a priest, he eventually changed his mind and supported an end-of-life transition. Additionally, Karen had friends who stepped forward who noted that in conversations, she had expressed that if the worst were to happen, she would not want to be kept alive by, quote, extraordinary means. In August of 1974, 4 months after her initial presentation, Karen's parents requested that she be removed from ventilatory support. They signed documents to release the hospital from liability, but the medical team refused, citing concern that this would be akin to murder. I've never heard that before. A month later, Karen's father petitioned to be appointed Karen's guardian, which would allow him to authorize discontinuation of life support. This was denied in November. 4 months later, the case was appealed and heard at the New Jersey Supreme Court. The judge was quoted as follows: "The matter is of transcendent importance, involving questions related to the definition and existence of death, the prolongation of life through artificial means developed by medical technology undreamed of in past generations, the impact of such durationally indeterminate and artificial life prolongation on the rights of the incompetent, her family, and society in general." Karen's case highlighted the competing interests of the state's mandate to prolong life versus the individual's right to privacy. Right to privacy here specifically means the idea that a person's medical decisions are none of the state's business. A right which was made possible by Roe v. Wade and Griswold v. Connecticut. The courts in Karen's case found the right to privacy would matter more as a patient's prognosis worsened. And they specifically highlighted quality of life as something worth considering in this determination. It's also worth noting that the judges generally showed their cards and placed a high value on a person being able to retain a, quote, cognitive and sapient state. The New Jersey Supreme Court, ruled in favor of the Quinlans and mandated the formation of prognosis committees, which are the forebears to modern day ethics consult committees. In May of 1976, nearly a year after her initial presentation, Karen was removed from the ventilator. She then lived in a nursing facility for 9 years before ultimately passing away from pneumonia. Our next case is that of Nancy Cruzan. Nancy was 25 years old in January of 1983 when she suffered a terrible car accident. Nancy was thrown from her vehicle and ultimately found on the side of the road in a water-filled ditch. She was resuscitated and intubated, and an NG tube was placed for artificial nutrition and hydration. Her initial diagnosis was coma, and 3 weeks later, she was determined to be in a persistent vegetative state. Again, still a bit sooner than what we would have done in modern times. Nancy could breathe on her own shortly after admission, but did require surgical feeding tube placement for ongoing nutrition and hydration. 5 years later, when it became abundantly clear that Nancy would not recover from her injuries, her parents asked the hospital to remove her feeding tube. The hospital declined in absence of a court order. Her parents filed for this, and a friend testified that Nancy had confided that if she ever had a catastrophic event, that she would not wish to live unless she could, quote, do so in at least a halfway normal way. Lawyers on behalf of the family stated, there is a fundamental natural right to refuse or direct the withholding or withdrawal of artificial life-prolonging procedures when the person has no more cognitive brain function and there is no hope for further recovery. Ultimately, this court order was approved, but Nancy's story did not end there. The Missouri Supreme Court got involved and reversed the original decision on the grounds that the friend's testimony did not meet the state's threshold for adequate evidence. Additionally, they declined to uphold the precedent set by Karen Quinlan and did not recognize Nancy's right to privacy. 2 years later, the case made its way to the Supreme Court for appeal. The court ruled in favor of the Missouri Department of Health, knowing that their requirements for evidence were not unconstitutional. The ruling also classified the right to refuse treatment as a due process liberty, and declared that the state's interest in preserving life in this specific case outweighed Nancy's liberty interest. Nancy's family were determined, however, and so in December, after accumulating more evidence of Nancy's wishes from friends and family, the court ruled in their favor. Her feeding tube was removed on December 14th, and on December 26th, nearly 8 years after her car accident, Nancy died. This is a picture of Nancy's headstone. You will note the ECG strip, which morphs into the words "thank you" before flatlining. Her family also requested that an additional date be added to her stone. January 11th, 1983, the date she departed, along with December 26th, 1990, the day she was finally at peace. During the last year of Nancy's life, Terry's long and winding case began. Teresa Marie Shivo, better known as Terry, was 27 on February 25th, 1990, when for reasons that are not totally clear, she had a cardiac arrest in the setting of a potassium imbalance. Terry was resuscitated and intubated, and then somewhere along the timeline, she was diagnosed with persistent vegetative state. A surgical feeding tube was placed, and she was eventually transitioned to a custodial care facility. As I mentioned in the last slide, Terry's story is a long and winding one. In 1990, her husband Michael was appointed as Terry's guardian. Michael and Terry's parents worked together to care for her for 4 years, during which time Terry received intensive rehabilitation services and even experimental therapies to try to reverse her condition. In 1993, Michael won a malpractice claim against one of Terry's physicians. And in May of 1998, after having come to terms with the irreversible nature of Terry's condition, Michael petitioned to be allowed to remove Terry's PEG tube. Her parents vehemently opposed this. 2 years later, after significant evidence was reviewed, including the testimony of 2 physicians brought forth by Terry's parents who stated full recovery was possible, the courts ruled in favor of Michael. Thus began a 5-year tug of war around Terry's feeding tube. It was removed and replaced twice. The Florida House, Senate, and Supreme Court all got involved. Ultimately, the Florida Supreme Court ruled it was not the state's place to make any such decisions under the separation of powers. In March of 2005, Terry's PEG was removed for the final time. Congress and President Bush signed a federal law directing a review of Terry's case, but the consensus declined to require her PEG to be replaced. Terry died March 31st, 2005, 15 years after her initial presentation to the hospital. The legacy of these 3 women is clear. Nancy is responsible for the right to privacy, where physicians can consider quality of life, not just quantity, in the decision-making process for patients with serious illness. Karen and Terry's legacy is that of the right to refuse treatment, where a patient or their surrogate, as directed by a patient's stated wishes, can decline life-prolonging treatment, including that of artificial nutrition and hydration. Collectively, these 3 women are responsible for the so-called right to die, where patients can elect to pursue comfort-focused care rather than the prolongation of life in the midst of serious illness. Stepping into more recent history, our 4th case is that of Marlise Munoz. Marlise was 33, an EMT and a mother to a young child, and 14 weeks pregnant with her second, who was found down on November 26, 2013. She was resuscitated and intubated, and later workup revealed that she had suffered a massive pulmonary embolus. Marlise was ultimately declared brain dead in the ED and then transitioned to the ICU. A quick pause to give some context to local law at the time. In Texas, Marlise's home state, the Texas Health and Safety Code, section 166.049, states that a person may not withdraw or withhold life-sustaining treatment from a pregnant patient. The law highlighted the ethical concern of the competing autonomy of a pregnant person and a fetus, a concern which I would say features heavily in local and national politics today. Marlise's husband, Eric, also an EMT, requested that she be removed from the ventilator support, as is typical after a diagnosis of brain death. Her family and friends were all in agreement with this decision. Because of the Health and Safety Code, Chapter 166, the hospital refused. In January of 2014, roughly 6 weeks after Marlise's diagnosis of death by neurologic criteria, Eric filed a lawsuit against the hospital to allow Marlise to be removed from life support. Eric's lawyer was quoted, "If Marlise is brain dead, she's dead. We don't talk about corpses having a condition, and we don't treat them, which is an additional reason why this pregnancy exclusion can and should be disregarded." 2 weeks later, the judge ruled in Eric's favor, and 2 days later then, Marlise was removed from the ventilator. While the court ruled in favor of removing Marlise from the ventilator, it declined to rule on the larger issue of whether limiting end-of-life decision-making in pregnancy is constitutional. Marlise's mother, Lynn Marcato, went on to work with the ACLU to draft Marlise's law, which would remove pregnancy as an exception from the aforementioned Advanced Directive Act. It was presented to committee twice, but was voted down each time. Lynn continues to be committed to this cause, and her work inspired the Almerico v. Denny case in 2021, in which an Idaho district court found an absolute pregnancy exclusion to be unconstitutional. This has not been met with mainstream acceptance. Which brings us to our final case. Adriana Smith was a 30-year-old nurse and mother to a young son who was 9 weeks pregnant in February of this year. In the days preceding her penultimate ED presentation, Adriana was evaluated in the ED for headaches. She was given medication and reportedly sent home without additional evaluation or workup. Then on the morning of February 19th, her partner awoke to find Adriana gasping for air. They presented to the ED, where she was found to have multiple blood clots in her brain. She was ultimately declared brain dead and transitioned to the ICU. We've heard about Texas law, but what about Georgia? There are 2 laws on the books which were felt to be at play during Adriana's case. The first is Georgia House Bill 481, also known as the Life Act or the Fetal Personhood Law. This is an anti-abortion law which was passed in 2019. It granted personhood to unborn fetuses, which, as you might imagine, has a whole host of consequences. It's also a heartbeat law, which prevents abortions beyond the first heartbeat on an ultrasound, which is typically around 6 weeks. Exceptions to this include when a physician determines in reasonable medical judgment that a medical emergency exists, or that a pregnancy is medically futile, or an official police report has been filed alleging the offense of rape or incest. This was originally ruled unconstitutional in July of 2020, but this was reversed, and the law went into effect July 2022 after the Supreme Court ruling in Dobbs v. Jackson. The second law was the Georgia Advanced Directive for Healthcare Act of 2007. This required a pregnant patient to be kept on life support if their pregnancy was viable, regardless of their wishes on documentation such as an advanced directive. If the pregnancy was not viable, then the patient was allowed to choose. But if they did not, the default was ongoing life support. April Newkirk, Adriana's mother, requested that Adriana be removed from life support, as is customary after a diagnosis of brain death. Her doctors reportedly stated that they could not do this because of her pregnancy until such a time as the fetus was viable and could be delivered. Several months later, Adriana's case reached national attention, with parties advocating for her bodily autonomy and others advocating for the personhood and autonomy of her unborn fetus. The Georgia Attorney General made a statement stating it would be legal to remove Adriana from life support under the Life Act, and clarified withdrawal of life support as being a distinct action from abortion. Despite this, Adriana remained on life support until June 13th, when she underwent emergent postmortem cesarean section. Her son Chance weighed 1 pound, 13 ounces, and remains in the NICU, now 5 months later. Several days after Chance's delivery, Adriana was removed from life support. Her obituary stated Miss Adriana Monet Smith passed away on February 19th, 2025. While Nancy, Karen, and Terry's legacy is clear, the impact of Marlise and Adriana has not yet been realized. The landscape around death by neurologic criteria, pregnancy, and the rights of the fetus is still forming as we ask these questions that to an earlier generation might have been completely inconceivable. So this was a nice history lesson, but where do we go from here? Medical technology and advances in the field are allowing us to ask questions with new ethical and legal implications. Two such questions facing my field are whether a patient with a non-terminal condition should be allowed the right to end their lives, or if a patient fills out an advance directive which directs cessation of eating and drinking, should they reach a certain level of disability, whose decisions do we value more? The quote sapient and cognizant patient who's or the one with severe dementia who just keeps reaching for a glass of water? These questions do not yet have answers, and perhaps like those asked in the course of these 5 women's lives and deaths, we may yet have many legal and ethical battles ahead before there is clarity. But those answers certainly will determine the legal landscape for future generations to come. Questions?
Yeah, it's like any major cases involving men. If it's just the like inclination of paternalism toward women over, the eons that has led to these cases being the ones that are at the forefront.
In my research, there was one case of a male child. I didn't include that, given that this is an adult population. But I did not come across any with men. Other questions, comments, discussion?
Within the state constitution, a right to privacy, but nationally, there isn't. I mean, there is court cases with kind of this idea of right to privacy. So how does that change, going from maybe a state like Montana, which very explicitly has a right to privacy versus other places where it's a lot more ambiguous?
Generally speaking, at this point, because of the precedent set by these women, so the right to privacy is one that made it to regional, as you mentioned, but then the individual's ability to make their medical decisions has become a liberty sort of right, and that did make it all the way to the U.S. Supreme Court, and so that's actually probably the one that overrides ultimately allowing an individual to make these decisions. I don't know if that was clear, but there is precedent nationally for people to make their own medical decisions.
You alluded to a little bit about Idaho law and its implications, but I'm kind of curious in the context of the story you were telling us. For us as physicians practicing in Idaho, kind of what considerations might come into play in some, some if and when some situations within this.
Yeah. I think it's important for people to read the advance directives that they are giving to their patients. So nationally within the VA, it's pretty neutral language. Doesn't have any discussion about a person's pregnancy status, but Idaho's does. And there's a box that you can check similar to Georgia. And so for those of us who work in the community, not just within the VA, I think it is important to talk to your patients who could become pregnant about some of these pregnancy exclusions. Idaho in general is one of it's more conservative in the rules around what a person can and cannot do once they become pregnant.
Not even sure if I have a question in my brain with all these thoughts. Those who don't know, I'm Dr. Scott Crow, rehab medicine physician, work with a lot of neuro rehab, progressive disorders, ALS, somebody currently in the ICU. Maybe at 9 a.m. will come off support. But some of the comments are in that context, like ALS, and what does informed consent mean? What is it that somebody thinks the quality of life may be. When you ask somebody way in advance, they can't conceive of what it actually might be like in the state. And so is that truly informed if you haven't kind of lived into it? Because I can attest that many people, maybe not in the progressive disorder, but for example, high-level spinal cord injury, and people would say in advance, no way in heck would I ever want to live like that. But then down the road, they're like, oh yeah, life's actually not bad. I can live this way. So is that informed consent, and can you accept their perspectives early? I would say yes, but what's then our obligation to help provide information of what it may be like? Like, do we accept the suicidal teenager wish that they want to die? We don't accept that. Is that the same as not accepting somebody in advance of, oh, I would never want to live that way? And again, I'm not sure there's questioning that, but given the extent of your knowledge of this, if there's any comments in those domains, it's just stuff that I've dealt with a lot.
Yeah, you've touched on an area within palliative care that we talk a lot about, which is, we always say that it's really important to have these conversations with your loved ones. What are your lines in the sand? What is your minimum acceptable quality of life? If you can, put that on a piece of paper. But what really is the ultimate value in that? As you said, how can a person really accurately understand what it is to have a high C-spine injury or a terrible TBI or to be severely debilitated from advanced heart failure? I think we see a lot of kind of what you're speaking to. I think of it as boiled frog syndrome, where once you're in it, you kind of get used to it. But there are also people who don't, right? They get in it and they're like, yes, this is every bit as bad as I thought it was going to be. I'm out. Thank you. Our country puts a high value and high priority on a cognizant and sapient state. So a person who is able to make those decisions in that moment at this time is held at greater value than the person who has lost capacity and can no longer, articulate a choice or can't, as our patient with ALS can't necessarily reason through all the ins and outs. And so we're really requiring that person in the past had a good sense of what their future self would want. It's complicated, and I think it's evolving. We do know that having these conversations, even if they don't necessarily change outcomes for the patient, and they do change outcomes for the survivors. So those who live on after their loved one have died will report improved bereavement if they've been able to have these conversations with their loved one, and if they've been able to document those conversations. Other questions, comments, concerns? This is a method for giving me feedback. I would love to hear it. I hope you all have a lovely rest of your day. Go forth and heal. Thank you. I got choked up a couple times. Yeah, man. And they do okay. I mean, I get to Marlies and I'm like, now. Yeah. Interesting if you're building on. You could like share. You probably don't have that many now, right? But like over the years. Well, yeah, I know where they're already on. I'll also leave it in. So I would love to hear. I would love to have some of those. Yeah. I was like, oh my gosh, is that? Yeah, I just read.
The nuances of well, when is it they become a decision and decision about what and when you realize because they allow current creature, right? And especially the changes like I swear I just heard this belief that statement and now I'm getting an opinion that I think is contrary to what I feel like I just heard, but then it's like, wait a minute, did you guys? Did you have mind in that 20 minutes when I wasn't there? That made it right. Now you're saying, well, you just mind at the end. And I said, well, we did. Maybe, I don't think you did, but I can't say no to you because you're MPOA.
every week. Send out
Oh, so that
people to click on and watch them. Another way that people can, because you might get bombarded every week with, hey, how do I get where can I watch these? That's another way. Or you can wait till I put them on SharePoint on the news page,
Yeah.
and then you could just send people that way. Either way.
I don't really get a lot. So
Oh, okay.
yeah, I just kind of